Yes, thank you. This is a little bit of a departure for me, and what many of you unlikely know is 5 years ago in the NICU at St. Christopher's, Maria Delavoria was my section chief at the time. She asked me to take on a role as the director of quality for the NICU to start to look at the quality metrics that were increasingly being demonstrated in the literature. So we had been following some of the epidemiology, not unlike all of your NICUs, but we hadn't really delved into the science of quality improvement. So what is quality improvement? Isn't it just the practice of medicine? I mean, that's what we do every day. We go into the NICU, we see something we're concerned about, we look for a fix. If we see a trend of something going a direction we don't care for, we try to dig into it, and that's what you've done so beautifully in this NICU. You have found areas of concern and delved into them and tried to tease out exactly what's happening and what can we do to have such exceptional outcomes. So it simply is the practice of medicine, right? You have a concern, you address it. Or like that Disney movie, Robots, find a need, fill a need. So that is the answer, but what quality improvements evolved into is a scientific evaluation. It's demonstrating change in a more systematic way. Are things better that we can measure, and can we demonstrate that that change has occurred, or does it just seem better? And is everybody who's truly involved in the care of that patient or that issue, the key stakeholders, are they involved in the change? Have they put their stamp on it? Have they given their perspective? Have we looked at it from all angles? So is the change different enough, better enough, to say that it isn't by chance, and can it be sustained? So the approach to this is oftentimes a lot of planning and a couple bits of terminology and some statistics, and then I will give you some examples from our NICU that will illustrate these points. So this part may seem a little bit dry, but when you get to the next part, it will all make sense. So we think in terms of key driver diagrams, Fishbone diagrams, another way of assessing or planning out what you're doing, PDSA, or plan, do, study, act cycles. Each time we do something, did it help? Can we stop and think about it? What can we do next? And the statistical approach, which is generally a variation of control charts. So this figure is a template of a key driver diagram. On the far left is your aim. What is it you want to see? You want to see your infection rate decrease by 80% over the next 3 years. You can choose your aim. That is the goal of what you're doing. Your primary drivers are the areas that need to be improved in order to achieve the aim, and then the secondary drivers on the far end, actually on the middle in the dark blue, are the things that affect each thing. So if you decide that you need to improve hand hygiene in order to decrease your infection rate, well, that doesn't just involve the physicians, that involves the nurses, all of the consultants who come in, the families, all of us remembering to clean our cell phones. There's many facets to that. And so many secondary drivers can affect the primary driver of improved hand hygiene, which could affect your aim of decreased infection. This is a fishbone diagram, and just to keep it a little bit more interesting, I gave you an illustration of a fake fishbone diagram. So the fishbone diagram on the right is really what happens in the unfortunate event that the coffee doesn't taste the way you want it to. What are all the things that can happen that can affect that? You went to the coffee shop and it didn't come out the way you wanted it. Is there a problem with their process? Is the coffee itself not a good quality? Is the equipment not working properly? Did you put in something that didn't taste right to you? Did you think that you were putting in cream and you instead put in skim milk? Or are the people around you in the coffee shop affecting how you feel about that coffee because they didn't treat you well? So what a fishbone diagram developed by Ishikawa in the manufacturing world is really to just look at what things can affect the output. So what goes into why we do what we do? It's a brainstorming tool. So if hand hygiene isn't as good as you want it to be for your NICU, why isn't it? Are there a lack of scrub brushes in an obvious location? Are people walking past them on their way in? Or did it seem like a good idea to put the sink in an inconvenient location so that it's easier to walk past it and not notice it? So this is that type of brainstorming before you even start. This illustrates a PDSA cycle, and you can have many of these in any improvement process. So you do a lot of planning, you think about what you want to do, you decide as a team, let's try something, because you really don't know what's going to work and what isn't. This is absolutely no different than laboratory medicine. You may have an idea behind what might work, but you don't know yet. So you try something, you evaluate it. Based on that evaluation, you sit down as a group, revisit it. Did it actually do what I wanted it to do, or do I need to sit down and plan and come up with a new cycle? And there can be a series of cycles that lead to incremental changes over time. So the statistical approach, it's the same as every other statistical approach. You want to be sure that what you're saying is different, is truly different, and not just coincidence. It's absolutely no different than looking at a p-value in basic science. Right? A p-value of less than 0.05 means that there's less than a 5% chance that that happened coincidentally. So whatever your outcome is it real? So in this type of change, there's always going to be some variability because things are going to be better one day than the next, different for one patient than the other. So how much variation in the real world is real and how much of it is just part of the process? That's where a control chart will help you, looking for anticipated or unanticipated variation. There are 8 rules for special cause variation, and I won't subject you to knowing all of them, but once you see what the graphic representation looks like, you want to see that the variation doesn't go too far for too long in any one direction. If it does, that's a real change, and then you change what your outcome is. But all of this sort of thinking and lingo and process is a true change in culture. And we've certainly seen it in our NICU and many other NICUs over the past 5 or 6 years. You'll hear the incoming trainees right out of medical school starting to ask, well, where are we in PDSA cycles on that project? These were words I had absolutely no idea what they meant 5 years ago. Like, I would not have known any of this at that point. It's all pretty straightforward, but you all are going to see much more of this in a scientific format in the literature, so it's a little bit of a primer. Control charts are the most common way to monitor a process, and this all comes from the manufacturing industry. So historically, it was always to monitor that on an assembly line where things happening, was the output what you wanted it to be? Had some variation happened that you deviated from your goal just so far that at this point, you're not making exactly what you intended? It has been less commonly used as an analytic tool, but I would say much more commonly in the practice of medicine. So when a process is completely stable, it displays common cause variation, meaning the peaks and valleys are what you think they should be. That's what it is in the day-to-day operation. None of us are perfect. None of our systems are perfect. And so there's going to be a little bit of variability. But can we, based on where we live normally, the status quo and the usual variation about that status quo, can we know when we've deviated far enough away from it that something's out of the expected? And if that's the case, there's special cause variation, and that's when those 8 rules apply. So they're basically tools for understanding process variability. So this is a control chart. So imagine you have time on this axis, and you have an average of data points. It doesn't matter what you're looking at for purposes of this example, but just say percentage of hand hygiene. Your goal is to always be perfect, but you're not always perfect. So from one month to the next, or 1 week to the next, this is the average percentage of hand hygiene events that are monitored. So you're targeting something, but you're varying. When you average all that variation, you get the center line, which is the orange line. Above it and below it are the control lines, the upper and lower control limit. They are 3 standard deviations away from the center line. If you stay within 3 standard deviations, most of the time, you're fine. If you live on one side of the center line for a significant period of time, you need to move your center line because that's no longer the average of where you're staying. This is another way of thinking of a control line. So what I just showed you in this format is the same thing as looking at a mean distribution, with the outer ends of it being your control limits are 3 standard deviations, and conventionally we look at 2 standard deviations. So this is more than a p-value of, or less than a p-value of 0.05, it's closer to 0.01. Busy slide just illustrates for you that there are a number of different ways you can input data into all of these programs to create a control line. And it has to do with whether or not you're counting something, you're measuring it in a percentage. Is it a frequent event? Is it an infrequent event? Is it a whole number? Is it a partial or a percentage, a fraction? But all of these will simply answer the same question once you see them in print. So I'll give you some examples from our NICU. We've looked at a number of things in a systematic way and created a series of PDSA cycles by putting together a team. Each of these circumstances, a problem was addressed or perceived, and a team was put together to tackle it. So I won't read them off for you because we're going to go through them one by one. So, unplanned extubations. Now, we all talk about how we want to ventilate fewer babies with endotracheal tubes, but when the tube is in, it should stay in until I intend for it to come out, because when it comes out accidentally, that can cause some complications for the patient. So, this was a matter of true need. We were summoned. We had this sudden peak in unplanned extubations. Now, the numbers that you probably can't see very well on the axis are, these are unplanned extubations per 100 ventilator days per month. So for this month, this is only a little bit more than 3, bearing in mind that there is no standard goal for unplanned extubations. Most of us want to get to 0, right? We never want this to happen. From a realistic perspective, the general consensus is to try to get ourselves below 1 per 100 ET tube days. So we created a goal of 1 per 100 ET tube days. We monitored this. This is month by month, and the green line is cumulative. So each month there's a data point. This team consisted of the co-authors are the NICU nurse educators, but the respiratory care teams contributed significantly to the success of this. So there are a lot of moving parts, but just to illustrate for you, there are 6 PDSA cycles so far. And until we get to 0, we're not going to be satisfied. But the idea of this is you figure out what is the scope of your issue and what can you do to gradually chip away at it. So by starting off by putting a NICU team together, we realized that although we said we taped ET tubes consistently, we didn't. So everyone was retrained, there was consistent taping, and it still didn't get better. So then we realized that when one person was taping with one of the providers holding the tube, it didn't always work out that well. So there have to be 2 trained people at the bedside. And step by step, each step in the process consisted of evaluating each unplanned extubation, pulling those people together and saying, show me what happened. Show me with a mannequin. Let's walk through this and let's see where this could have been done differently. Remember, our goal is to be below 1 per 100 days. So it would be lovely to be 0, but we are not 0. Although, oops, if I go the other direction, you can see that our average has maintained a level below 1 per 100 since shortly after the project began. So this is an example where the metric itself is really answering the question. So we heard about central line rates and how low your central line rates are. This is a metric that we have to report to the state and also federally in the United States. So this was a big ticket item. There was a lot of interest. Infection prevention was interested. ID was interested. Infectious disease, because they didn't want us giving antibiotics if we didn't need to. We didn't want to have more infections because those can impact the long-term outcome of our patients as far as their long-term neurodevelopmental outcomes as well as their rates of BPD. So overall, this is a big ticket item in every NICU, right? So in our nursery, we participate in something called the Solutions for Patient Safety, which is a consortium that has experts that help create pathways. If you put these bundles together with evidence behind them and you follow the bundle religiously, can you reduce your CLABSI rate? And this has been demonstrated and published. So we looked at our bundle compliance. So in our NICU, for the average baby that had a central line, what bits and pieces were we good at, and where did we have an issue, and what weren't we as good at, and what could we do better? The way we look at bundle compliance, even though you're going to see a lot of things here, it's all or nothing. You followed everything that we prescribed to in our NICU, or it was a 0. So you were either compliant or non-compliant. And we realized, without a whole lot of effort, that we, the providers, weren't great at documenting a daily discussion of the need for the line. And so we chipped away at that one, because if you talk about it, you might figure out you don't need it, and that might take off 1, 2, 3 days. Every day you take away takes away risk. We also realized that we were using chlorhexidine baths for infants that were past their due date to reduce skin colonization rates in a hope of reducing line infections. It is a recommended but not required element, but in our institution it's required. When we started looking at this, and this is a key driver diagram, our goal was to improve bundle compliance. Figuring it's already been proven that if bundle compliance is better, then your CLABSI rate is lower. So we didn't go into this trying to reduce our CLABSI rate because our rate was already fairly low. So we could put a large team together, we could put a lot of work into this, and as chance would have it, we might have 2 that year, having had 1 the year before, which would defeat everybody's perspective in this circumstance. So we sought to go after where we thought we had an issue. How could we improve bundle compliance? As we started chipping away, we looked at the major fallout. So those are the things that we know are impacting our compliance. When one of the fallouts was clearly identified as chlorhexidine baths, we met with the pharmacist at the suggestion of one of the NICU nurses who realized that on the back of the bath wipes, there was a UPC symbol. We weren't scanning them. These could be added to the electronic medical record, the EMR. We could prescribe them. They could be scanned when they were administered, and it wouldn't have to happen when somebody remembered to do it on protocol. It sounds so obvious to see that UPC symbol, but I can assure you we had them in our institution for 5 years with computer order entry and never thought to do it before one nurse came on rounds and said, why aren't we scanning them? So by changing that, we had to include all of the key stakeholders. We needed hospital administration to pay for a change to the medical record. We needed pharmacy leadership to agree to add it to the electronic medical record and now dispense bath wipes as if they were a medication. And then we had to operationalize this by training everybody in the equation and continue to track it and monitor it and see where the steps were. But the second piece of this, not only were we able to improve our bundle compliance, and this is a standard percentage over time process control chart, a P chart, you can see that very shortly after we introduced computer order entry, our bundle compliance went to nearly 100%. We had 1 bad month. So as you can see, the upper and lower control limits are a little hard to see. So the upper control limit is 100% for the most part. The lower control limit is this dashed line. Once we have 8 sequential points above that dashed line, we're able to move our center line up to say that we truly actually had a demonstrated statistically improved change. So this was what I was referring to by changing your center line or changing your average. So we were able to show that our compliance went from 77% to 99%, and that's statistically different by this model. The other interesting thing was, why was this so successful? Because this is the unique example of a QI project that was less work. It was more work before. A charge nurse was going through the list of all the patients, looking at their post-conceptual age, determining who needed them, reminding the bedside nurse, who was remembering on her shift at night typically, to go get the bath wipes, not to forget to leave them at the bedside, and to actually do it and chart it. So by doing it this way, we were able to save all of these light blue steps or clicks, if you will, in the electronic order entry. So it was a process improvement that helped our patients. We were increasingly compliant with this infection reduction bundle, but we also saved almost 33,000 steps in the computer charting, which for everyone has become increasingly tedious. So this project was led by one of our neonatal nurse practitioners, one of our educators. Dan Naylor participated, who was one of our information technology people who worked on the computer order entry data set. Andrea Levine was one of our infection preventionists. So as you can see, it takes a multidisciplinary team to make something like this happen, but something as simple as scanning the UPC, and it's less work at the bedside, which is not usually the outcome of a quality improvement project. So this also demonstrates that bath compliance specifically was where the change really went up. So then, one by one, people are hearing about increasing different processes, and as well in the United States, our neonatal fellows are asked to participate in a quality improvement initiative where they can demonstrate how the process evolved, successful or not successful, as part of their fellowship training, because this is increasingly the way the practice of medicine is being described in the scientific literature. So this project was led by one of our fellows, Sam Ajay, as well as my colleague Fola Kahindi and David Cooperberg, who was one of the QI gurus in the Department of Pediatrics who taught me how to understand this process. Whether or not you give antibiotics to infants born to moms with chorioamnionitis isn't really the question. In this project, it was a focal population of infants that we were giving antibiotics to. So what could we do to make sure that the blood culture was done and the antibiotics were in the baby within that golden 60 minutes, which was our target? So this key driver diagram was built before the process was started. There were several meetings to determine how could we reduce the number of patients or increase the number of patients receiving antibiotics within an hour by 50%. So in this circumstance, the monthly data was averaged. So it's a slightly different chart. It's an X-bar chart because you're plotting averages. And then there is an S chart, which looks at the standard deviation of each of those averages every month. What you can see is our average time to antibiotics for this focal population was 130 minutes at the beginning of the project. Shortly after the first and second intervention, we have a series of points below this center line, allowing us to shift the line down. Now, at the point of completion of this project, we were at 78 minutes. And the reason this project's complete, and you may wonder we didn't hit our goal of 60 minutes, is twofold. We adapted the NICHD sepsis risk calculator, so we are not admitting these babies and giving them antibiotics, which is number one. And number two, this fellow also graduated. Having said that, the goal of that was really to show if you pick a population, can you have a process occur within the fixed time? Could you get the patient admitted? Could you have the IV in, the blood drawn, the meds in the patient? So you could apply similar logic to other processes. This is a project looking at, with our infectious disease colleagues, could we reduce the use of antibiotics? So globally, we're all looking at antibiotic stewardship. We know that the microbiome of the lung and the gut are very important to our infants, and that we're altering these every minute they're on antibiotics. So clearly less is more. And so what are some ways we could target that? The infectious disease team and infection prevention built an antibiotic stewardship team, and they were contacting us and calling us and suggesting that maybe we stop or change or minimize or narrow antibiotics. And as a neonatologist, you can just imagine how well received those phone calls generally were. So instead, we decided to sit down as a team and say, what can we do to tackle this together? Because we're all in this together. Let's not make it adversarial. I don't like the idea of somebody calling me and changing what I'm doing. I didn't consult. I'm just sitting here minding my business, managing my patient. Someone's making fairly unsolicited suggestions. So what can we do to put our heads together? Where do we think we have problems? We're very different than the ΜΗΤΕRA. We are 100% referral-based, predominantly surgical NICU. So we do have a fair number of patients that come in with necrotizing enterocolitis. So this is a two-part project. Our neonatologists and our surgeons sat down with infectious disease and said, what is going to be our treatment algorithm for these patients? Can we agree on antibiotics? Sight unseen of the patient, if you were stage 1, if you were stage 2, if you were stage 3. What will the doses, what will the antibiotics be, and what will the duration be? And interestingly, the meeting was shorter than I ever would have believed, and there was impressive agreement for antibiotic regimens for necrotizing enterocolitis to be led by the neonatal team. But we all agreed. So over here you can see the algorithm. As this was occurring, one of our fellows wanted to look at how did we adhere to that pathway at the same time that the antibiotic stewardship folks were really interested in trying to see, could we reduce our use of vancomycin and meropenem, two of the broadest spectrum antibiotics we're using. Again, less is more. The shortest duration, the lowest dose that's effective, and the narrowest scope. So what could we do to minimize both of those? So interestingly, you can see over here, this time are U charts, and only because we are looking in this case at antibiotic days over total patient days. So when you have an infrequent occurrence over a very large denominator, a U chart is the type that you'll use, but there's a pathway to figure all this out. So what you can see is when we start the project, the top one is vancomycin. Our center line is fairly high. Our percentage of or days of vancomycin use per 1,000 patient days was 114.6. Once we built and developed and started using the necrotizing enterocolitis algorithm, we reduced that to 58.6 days per 1,000 patient days. So there's a dramatic decline. There's a further decline when we sat down with the antibiotic stewardship folks and said, how about we do this differently? How about we don't get phone calls during rounds. We don't get phone calls when orders go in. We meet at 3 o'clock every day and go over who's on antibiotics, who could we do this differently for, and have a discussion instead of a call and do this. So that was changed, and the process they then called post-prescriptive review and feedback. So that's the lingo that they're using. In the vancomycin use, we were able to further decrease from 58.6 down to 33.2. So you'll see that there are 2 drops in this center line. So that's major headway. We then started also looking at meropenem. Meropenem was very minimally affected by the change in the clinical practice guideline for how we manage NEC patients, but dramatically affected by the discussion with our ID colleagues. Likely that these kids are coming in so sick. I know the pathway is saying I don't need meropenem, but I'm looking at a very sick patient. It feels uncomfortable to narrow the scope, unless, of course, I have my ID colleague standing right next to me validating that. So we believe that the prescriptive review and feedback was more successful for meropenem, reducing the meropenem days per 1,000 patient days from 24.5 to 18.4, and then down to 10.1. So dramatic decrease in total antibiotic use for our global patient population. So then the question becomes, is this just good timing, or can you prove you're really adhering to this NEC guideline? This is just the same thing. So Geoff Bourgeois, who at the time was a fellow and has since graduated and joined one of our community affiliates, Yannick Vibert, one of my colleagues, as well as Ishminder Kaur, who is the infectious disease doctor leading in antibiotic stewardship in the institution, Vineet Bandari and I, started looking at this. Could we achieve greater than 90% adherence to the guideline? Because maybe 10% of the time somebody's got a good reason, but we can't tell from the chart. But could we do it with, could we get to greater than 90%? So in the same timeline, you can see that before the guideline, agreement and following what the theoretical guideline was going to be was quite poor. We were in the 12% range. After the guideline and reinforcement and education, we're well into the low 70s. We haven't gotten it quite up to greater than 90%. And you can see that the upper and lower control limits are quite far apart. So there's a lot of variability in what people are doing, but we are certainly increasingly adherent to these guidelines. So it does seem to match not only the timing, but the adherence to the guidelines. So that's the second step of this. And so the similar concepts have been applied in other ways. Hepatitis B vaccination. Sounds simple enough, right? You get it within 24 hours if you're term, if you're over 2,000 grams, and you get it on day 30 if you're under 2,000 grams. It's not as simple for 72 trainees in peds, plus an additional 12 in fellowship, plus an additional 8 plus 5 per diem NNPs, to remember that when the baby comes in at random day of life, bearing in mind no one's born in our hospital. So we realized that we were pretty poorly compliant. So our compliance rate was about 20%. So we started reminding people, putting up signs, and just kind of quietly seeing if maybe a little bit of visual reminders would help. And it increased up to 33%. We then started calling people once a week and reminding them to look at the age of their babies and don't forget the rules. We got it up to the 80s, and then it coincidentally, I believe, has drifted a little bit. I don't think I can blame it on that last cycle of the pharmacist reminding us, but I do think that we're seeing a little bit of an upsweep here. But keeping people, getting people to remember things that occur infrequently and at variable days of hospitalization for a patient can be difficult. Lastly, transitions of care, one of the highest risk things we do. The main reason nurses years ago went to 12-hour shifts from 8-hour shifts was to take one less handoff out of the equation. So at St. Christopher's, we're one of 5 centers in the United States that participated in the IPASS study. And IPASS is a mnemonic for a standardized handoff tool. It was developed and validated in these 5 centers, and it was able to show a reduction in medication errors specifically by having a very standardized way that you hand off the patient and you plan for contingencies that might happen at night, bearing in mind that day shift rounds on the patient and night shift may not be as familiar with what was discussed. This was developed and validated for the med-surg floors in the pediatric hospitals and one adult hospital, but not really applicable to the neonatal community, and there was a lot of resistance, like, how will this work for our babies? I doubt it. But we had 2 very eager fellows who have since graduated, and one stayed in our group, and one is at one of our referral centers, who were interested in developing their own version, a NICU IPASS handoff tool that would apply to our patients, whether they were lower acuity or higher acuity, even those who are on ECMO. So they developed a standardized handoff tool, and we're looking at what's the impact on communication failures, when don't we know what we need to know for our patients, interruptions during handoff, because interruptions stop the flow of communication, and now we're not all having the same conversation, things get missed. And would it be efficient? Because that was the last hoop to jump through. Once we convinced everybody it would make sense to standardize this, the thought was, but now when we do it for the level 4 NICU, we're going to be in sign out for 4 hours. It's already long enough. So they developed, with members of the IPASS team, a training module that they then validated and did feasibility studies. So this is the way handoff occurs in our NICU and has for 2 years now, a little over 2 years actually. So this is a process map of how the handoff was happening to try to sort of get to the root of, was everybody there? Where were the holes? Why were interruptions happening? What are the issues and how can we tap into them? So this is similar in concept to a fishbone diagram. But then they created one. So this is a fishbone diagram in real life. So we didn't really have a standard way of signing out. There were a lot of different people with a lot of different levels of expertise involved in handoffs. The patients are complicated and critically ill, so could it even work? Was technology helping us? Absolutely not. They were handwriting and hand typing the handoff and then taking notes on it as they were talking amongst themselves. And what about the environment? Well, if you're right in the front of the NICU, if you're in what we call our fishbowl workroom with a wall of windows, it doesn't make it very conducive to a lack of interruptions. It makes it easy for people to know where you are and then just stop for one quick thing and one quick thing and one quick thing. So with all of this combined, it seemed like we had pretty lengthy and pretty inconsistent handoffs. This is a much more complicated key driver diagram because there's a lot more things in the equation. So could we avoid interruptions, decrease interruptions by half within that period of time? And then could we make sure that we had already communicated things we were worried about happening to make sure that the night shift knew what was expected? And this will show that in the top one is the X-bar chart, just showing it's feasible to do it. And could we, by doing this in this feasibility study, avoid interruptions? So this axis is the number of interruptions, and you can see that the control line drops with multiple interventions, including a move to our brand new NICU. The S chart shows you the variation in these monthly metrics, and you can see that there's less and less variation with time. What happened to handoff duration? It started off at an average of 71 minutes. With some initial changes, it went down to 55 minutes, and now it's down to 44 minutes. So not only is the handoff more consistent, are things missed less, but it's also faster and more efficient. So that's another way of increasing your buy-in. If something's easier, people want to do it. And then if you worry that maybe this previous data is clouded by patient volume, the per patient handoff is also reduced. So we went from close to 3 minutes a patient to close to 2 minutes a patient for essential information. I'll skip this one. This is the foreseeable but not communicated events. And you can see that less than 10% of the time that's happening. So when you do these types of studies, you learn from your successes, and then you can apply it to the next time you want to do quality improvement. Our successes have told us that multidisciplinary is if it's not multidisciplinary, that's an absolute deal breaker. You need everyone that's going to touch that process on any level involved. It's multi-pronged. It's going to be many cycles, many layers, and anything where the electronic medical record or computer order entry can assist you makes it easier for everyone. Some of our less than successful or failures, things that have limited preventability. So, or things that are not really a problem. So one of the studies I did not show you because the line is straight. 1 to 1.5% of the time, a baby comes back from the operating room colder than we're comfortable with a low post-op temperature. That is such an infrequent event, it's difficult to decrease it. So that was one of our less than successes. And the last lesson we learned was, on top of being an IPAS center, it was beyond belief how this took fire. I mean, it went through the entire NICU, and now at every level, IPAS is the handoff tool that's used. So it is for every nursing shift handoff, every pre and post-op handoff with anesthesia, and every medical handoff. So once it became evident that this was succinct, effective, and beneficial to our patients, people were asking for the team to build handoff tools for them. So the other sort of take-home message is your success creates success. So with that, I will conclude.